Welcome to what I think is going to be quite an interesting pair of sessions this morning. My name's Neil Ferguson from the University of Toronto, and I'm going to be co-chairing this session with my colleague Damon Scales. He's just handing over the ICU. That's his weak excuse for not being here right now, but he'll be along very shortly. The session we have today is focusing on end-of-life care in the ICU, and this is a session that we've put together jointly with the Canadian Critical Care Society. And I'd like to acknowledge Lisa Kenny, who's our first speaker this morning. She's an assistant professor at Memorial University in Newfoundland, formerly from Toronto. And so we still like to claim her as a Toronto person. She has a lot of work putting into this session, and we'll also be kicking it off with the talk, why is this such a problem? Why is end-of-life care difficult for us at the bedside? Welcome, Lisa.
Thank you, Neil, very much for allowing me to do this clinical talk. There's no monitor up here. Okay, I'll have to just wing it.
See here.
Okay.
Yeah,
not a problem. Okay. All right. So when Neil asked me to do this talk, being a physician, I would guess I was very egocentric, and I was saying, yeah, I find this very difficult at the bedside. But really, we really have to talk about why. When we talk about why we find end-of-life care so difficult for whom? And really, the focus should be on the patient. The SDMs, families, the bedside nurse, the respiratory therapist, the physician. Hospitals certainly find this difficult. Governments and HMOs, it's a big burden on our healthcare resources. And certainly quality improvement researchers find this area of research very difficult. So obviously end of life is about death. And death is not the outcome that us as healthcare providers want for our patients. So heaven, everyone talks about it, but no one wants to go there. All right, this is something that I kind of stole from the internet. I hope there's no copyright people in the audience, but it's just a picture of what we feel would be a good death. So a patient surrounded by their family, there's a cat on the bed, their good book. Seems like, if death has to happen, the patient seems comfortable. This is a picture of a good death. And so the same artist did a rendition of an ICU patient. So this is an ICU death. So certainly it goes without saying, one looks a lot more comfortable than the other. So end of life may be difficult, but it's a major component of what we do in critical care. We have very high mortality rates in our unit, and depending on what type of unit you practiced in, the mortality rate can be very low in a CV unit, even less than 8, definitely, or as high as 19%. And most patients who die in the ICU die after a decision to limit or withdraw therapy. So in most cases, it's a very controlled environment. And this is a bit variable around the world, anywhere from 34 to 80%. And just from my previous clinical experience at the Western, I presented some of this data in 2009, and I just stole the slide from there. We had an average number of admissions of 850. We had a raw mortality rate of 18%, which was very high because we were a tertiary care neuroscience referral center. And withdrawal of invasive support happened 67% of the time. Now, I'm not sure if those values have changed since myself and Dr. Ferguson have stopped attending at the Western. Maybe we'll have to check with Jeff Singh and see if our mortality rate has improved since our departure. But anyway, it's a very common event. Okay, and it's going to become more common. Rob Fowler is going to talk to us a little bit later about how Canadians die and our changing demographics. But we're going to experience a silver tsunami. All right, we certainly have an aging population. And we're certainly pushing the boundaries of human physiology. Cancer survivors, adult congenital heart disease, and transplant recipients, just to mention a few of the very complex patients that survive to go on to have complex critical care later on in life. So what are our performance indicators? Whenever we want to improve a difficult situation, we have to have some outcome measure. And really the gold standard here is very difficult to measure because it's the patient's assessment of dying and death. And that's very hard to capture, although, you know, in the palliative care literature, up until the last, I guess, few hours or few days of life, they've tried to capture the patient's dying experience, but in the ICU, it's almost impossible. So we use surrogates, and there's a number of standardized tools to assess the dying experience. The quality of dying and death instrument was developed in the general palliative care population, but then was tailored to try to capture the measuring the quality of the patient's experience in the ICU. And they did that through the nurse's perception of the patient's experience and the significant others' perception of the patient's experience. And then there's also tools to assess the clinician's skill at providing high-quality end-of-life care from the patient's, families, and healthcare providers' point of view. So outcome measures are very difficult to improve because it's a system of care, and especially in critical care where there's changing of attendings, changing of settings, it's hard to capture where the actual problems are. This is a framework, and this is just one of many frameworks of the 7 end-of-life care domains. And it just tries to break the process up to a number of different domains where we can actually try to capture where we have issues in our units and where we can improve. All right, and this domain was just created from a project sponsored by the Robert Wood Johnson Foundation. And they actually try to assess the palliative care process, but I'm just using this framework kind of to touch on a couple of particularly difficult areas. So the first statement said, patient and family-centered decision-making. But we even have to step back further than that. All right, can we recognize a dying patient in the ICU? When do the goals of care shift? When does end-of-life care begin? So, as physicians, we are very poor at giving prognosis, and you can make so many statements here and back them up by some observational study. But in the terminally ill patients, physicians tend to overestimate survival. This is just an example from a trial done by the Canadian Critical Care Trials Group on withholding mechanical ventilation in anticipation of death in the intensive care unit. The outcome of this, the end statement of this paper was that physicians' perception of patients' prognosis was a stronger determinant of withdrawal, more so than age or severity of illness. But it's quite interesting when you read this paper. In patients who mechanical ventilation was withdrawn in anticipation of death, 3.6% of patients survived to discharge. Never just survived to be discharged from ICU. They'd survived to discharge from hospital. Okay, and this was in Canada where we don't have we don't have any long-term ventilation hospitals. So that's a little concerning. So if we just focus on patient and family-centered decision-making and communication, it even gets more complicated than that. Doug White was here, I'm not sure how long ago, a number of months ago, and he gave a great presentation on the mechanisms of discordance about prognosis between clinicians and surrogates. And he contends that we do definitely communicate to patients, to families, with 81% of families or SDMs being given prognostic information and given it fairly quickly in the ICU stay. However, I'm not sure if this presents very well. This is a very concerning slide. So basically, there's a lot of statements up here, but if I just take the top, it says if if I make a statement to a family and I say, I think they have a 95% chance of living, if I look at the interquartile range of what the families perceived as the prognosis, it's very tight. So if I give a good prognosis, the interquartile range is very tight. If I give a poor prognosis and I say to the family, I think your loved one has a 5% chance of surviving, the interquartile range becomes very large. And some family members actually perceive that there's a 40% chance of survival. Okay, so that's very concerning, and he calls that the optimist bias. So even when I am trying to effectively communicate, I don't know if they really are hearing what I'm saying. So there's multiple tools. There is actually a lot of resources available to help facilitate communication, and this is just a mnemonic that helps us communicate with patients and families at the end of life. And so it's value comments made by the family, acknowledge family's emotions, listen, understand the patient as a person, and elicit family questions. And I think the most important thing is to try to communicate to the best of your ability, knowing that this is a very complicated process. So I can't go into all of these different domains, and you guys are clinicians and you see this by the bedside, but certainly in critical care we have a fundamental problem with continuity of care. We're usually on a 7-day cycle. The families and patients get a new physician. This transition is certainly hard, and there's probably not a whole lot we can do about that. But I just want to focus on symptom management and comfort care. So within symptom management, do we withhold, do we withdraw? Certainly in Canada, withholding and withdrawing are considered equivalent. There's many barriers to effective symptom management. When we withdraw life-sustaining therapy, what are our goals? Do we prevent symptoms? Do we wait for symptoms to occur and treat symptoms? How do we effectively withdraw mechanical ventilation? There's certainly some recommendations and some guidelines and some standardized orders. This actually is a paper that when I was in Toronto, I don't think I've ever read this until I started to work on this procedure of withdrawal of life-sustaining therapy project. But this is a paper done by Laura Harlick, and it was a consensus guideline done in 2002. It's actually a very nice overview, but it contains 16 guiding statements. And I think it's certainly worth a read, and I certainly don't have time to get into it now. But it's quite a nice paper. This also is a lovely paper to help guide us through this process. And this paper was written in 2008, the recommendations for end-of-life care in the intensive care unit, a consensus statement by the American College of Critical Care Medicine. Very good paper. All right. But it's important to know that there's no evidence that we really change any outcomes. Even when you get very granular and have a standardized order set for the withdrawal of life-sustaining therapy, we don't really improve, there's no improvement in the quality of dying and death instrument, but certainly the nurses and physicians found the order set helpful. All right, so I'm not sure if I really have given you any, practical advice by the bedside. Today at noon, the Critical Care Society is supporting a consensus meeting, and we've brought together people from across the country, and we're going to have a discussion about the actual procedure of withdrawal of life-sustaining therapy. So one small aspect of the topic, but we're just going to focus on when a decision has been made, when we withdraw life-sustaining therapies, what guidance should we give to clinicians, and what should our process be? And I'll leave it at that. Are we taking questions now?
Ma'am.
Okay.
Thanks very much, Lisa. We do have time for questions. This presentation's open. Please come to the microphone and introduce yourself while we're waiting for people to make their way. Let me ask you a question, Lisa. what do you think as clinicians at the bedside we should be using to judge sort of the quality of the dying process? Obviously, when we think of outcomes normally in the ICU, we think about saving lives, but that's not the right outcome for this situation. Is there something we can use clinically to help us know whether we're doing this properly or not?
So you're talking about assessment of discomfort by the bedside. Oh. Yeah, and certainly there is a number. Strangely enough, there is, and I really wasn't aware of this until I started this process just in the last year and a half. There are a number of standardized scoring systems, but they really haven't been proven to be any better than clinician experience. And it's not just the assessment of discomfort. Whose assessment do we use? Is it the bedside nurse's assessment? Is it the physician's assessment? Is it the families and SDM's assessment of discomfort? Because even our definition of discomfort, means different things to different people. But certainly, and then there's things described in the literature like bispectral EEG, which I don't think should be our should be our target.
Okay. Thank you very much.